Hello, my name is Ravi Vij. I'm from My Cancer Haven, and for today in our conversation with Cancer Expert series, we're going to be talking to Dr. Arihant Jain, who's at one of the leading hematology centers in the country in India. He's going to talk to us about myelodysplastic syndromes and give us somewhat of an Indian perspective. Welcome, Arihant.
Well, thank you, Dr. Ravi. It's indeed a pleasure to interact with you and to interact with uh, the audience at this wonderful platform.
Thank you. So, could you just give us some just overview as we start? What is myelodysplastic syndrome?
So, myelodysplastic syndromes or myelodysplastic neoplasms, as the newer versions of WHO call it, they are kind of a group of clonal disorders where the predominant manifestation is characterized by cytopenias, unlike the more common term or blood cancers or leukemia, where it's more of the high counts, particularly in the white count, where we see the where we see increased counts. But here it is typically cytopenias, and which is as a result of abnormal hematopoiesis. And if we look a deeper dive into the molecular pathogenesis, it's actually a clonal process which is going on at the, say, a stem cell level, which is causing this. And the other key point is they have uh, uh, tendency to transform into a frank acute leukemia at various stages on their follow-up.
So,
So,
how do patients usually present? What are the symptoms they seek medical attention for?
so I think there can be two or three major group of symptoms. So one thing is a lot of times they are incidentally detected, particularly so the age group is kind of uh, more as we age, the incidence of these problems is going to increase. So these are kind of thought as age related problems unless we specifically look into some germline predispositions which are there, but those are much rarer. So one subgroup would be the patients who just got a blood work done for, say, a routine health checkup, or maybe they were undergoing a surgery, and then they picked up a cytopenia or one of problems in one of the three blood lineages. To be more simplistic, either an abnormality in hemoglobin or in the white cell counts or in the platelet counts, which are incidentally detected. That can be one form of presentation. The other form is that they are, which kind of is more common with respect to Indian scenario, would be that they have these cytopenias which are going on. They are getting transfusions at a center. Initially it is thought to be as a say a nutritional problem, or people just think that it's a low hemoglobin problem, and they are getting transfused and still they are not getting better. When they are referred to a higher center where more workup is done, and that ultimately leads to the diagnosis of MDS. So the anemia predominant is more common. The other type would be the thrombocytopenia, which can manifest either in the counts or, say, bleeding manifestations. More rarely leukopenia or infections as a result of that, or a combination of these findings. So those are the so cytopenias and clinical manifestations of their cytopenias. That
So, how common is it? What do we know about the demographics in India?
So as the slide shows, it's so in fact all blood cancers are kind of coming a decade earlier in India as compared to the West. So that's how it is. Uh, with respect to but the population prevalence, it's still, I would say, a rare disease with less than 1 to 5 per million population. So, but the exact true Indian estimates are actually lacking. This is more of the international literature which I'm quoting. So that's one thing. And as the other thing is going on, as we have more and more uh, cancer therapies coming up, and most of our patients are living longer and longer, we are definitely noticing a reasonable proportion of secondary MDS, which are a result of prior cytotoxic therapies. And so environmental exposures is kind of, again, uh, more of a debate, and we need more stronger studies to actually prove the causal associations between, say, pesticides, pollution, heavy metals, and whatnot.
So I think you've talked about the common presentations, but how do you go about diagnosing it?
So I think here the uh, probably here our approach may be slightly different from what is followed, say, in the West, where we would like to. So anemia is reasonably common. Say, even I think the last Ministry of Health and NHS survey said that around 50% of adult males in the India were also anemic. So anemia is reasonably common. Again, thrombocytopenia is also reasonably common. So we would first like to kind of rule out the common causes of uh, uh, cytopenias first, which would mean that we would test them for an iron profile, whether they are iron replete or not, whether they are B12 or folate replete or not, whether they are losing blood from any other side, whether there is a immune component to their, say, anemia or thrombocytopenia. So once, say, again, thyroid is a common problem which may present with a high MCV and some cytopenias which are there. So once all that has been ruled out and the cytopenias are persisting, that is when we would be seriously thinking of uh, ruling out an my underlying myelodysplastic syndrome. And obviously, to confirm that, peripheral smear or simple blood work is usually not sufficient to confirm the diagnosis. So there may be certain clues in the neutrophils or a high MCV which may point you towards the diagnosis of an MDS in an appropriate age setting. But ultimately, it is the bone marrow morphology, and to support that, we have the cytogenetic and molecular testings, which are now, I would say, uh, reasonably available at most tertiary care centers in India as well. And even sometimes you have to be very careful because soul morphology can be challenging to diagnose, because there can be non-specific things which are coming up. So
So you
bone
mentioned
marrow and molecular studies and
So
cytopenia.
obviously, you mentioned that these require often ancillary support beyond morphology. So how prevalent is the ability to do these fish studies? Are these what we call these NGS panels that have multiple genes that you screen for? Are these easily available?
So access to these tests, say, I would say, in the tier 2 studies, it's still a challenge in the country, but uh, in the bigger cities of the country, and because we have a lot of these molecular labs which have come up both in the government funded institutes as well as in the private setup, the diagnostic challenges are becoming lesser and lesser. The I would say the more important challenge is the awareness and the sensitivity of the primary care physicians to this diagnosis, and that is where we actually face a significant delay in from the symptom onset to the diagnosis interval, which if I ball roll my mind, it would be somewhere between 3 to 5 months at our center.
So, if you had to order a next-gen sequencing panel, do you have one that PGI has in-house? Do you send it out to a commercial lab? How does that work? What's the turnaround time?
Yeah. So, uh, these NGS panels are actually continue to evolve. So, until say in the initial years of my practice, I would say till 2022, we were outsourcing it to the commercial labs, and they were reasonably, I would say, costly. Uh, but for past few years, we have our uh, in-house next-gen sequencing, which is available, and a lot of uh, targeted PCRs, which are also available at our center as well. But and they are very easily available uh, 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 in the private setup as well. So that's one part of it. Again, the costs has have drastically come down over the recent years from say costing 20,000 INR rupees till 3 to 4 years back to under 10,000 Indian rupees, uh, both in the government setup, so as well as in the outsourced labs as well. Turnaround time, I would say, is still a kind of a little bit of an issue, but the average I would say is 2 weeks. So we do get those results to us in 2 weeks, and as we all understand that MDS are, I would say, relatively slow growing or diseases, and 2 weeks is a reasonable time for us to kind of get those results.
Yeah, and I think that even in a number of institutions here in the United States, 2 weeks is very common as the turnaround time. Sometimes it can be even longer. So that's, I think, very reasonable, turnaround time. So then moving to the therapeutic. So how do you approach myelodysplastic syndrome when you do have a patient?
So that's kind of the more again a challenging part, because as we all understand that myelodysplastic syndromes in itself are a kind of a big basket, and they are kind of heterogeneous, with the low risk ones having survivals ranging in decades to the very high risk ones where the survival may be limited uh, uh, in somewhere between months to years. So and that's what would decide our therapeutic strategy. Again, besides the disease related factors, which to be precise is the risk stratification. We are using IPSS-R as revised IPSS and IPSS-M currently to kind of risk stratify our patients. And in addition to that, we have to look at the patient specifics as well. What are their preferences? What is their access to kind of say more intensive therapies? How much they can afford a particular type of a treatment, and how much they can tolerate, because these are kind of disorders of elderly people, and they would be on multiple comeds, and then there can be issues in kind of choosing the right therapeutic strategy. So it's, I would say, highly individualized. uh, Also, we have to understand that other than allogeneic stem cell transplant, uh, I would say, which is kind of the only curative option which we have. And in our setup, that option is kind of uh, uh, implementable in say 1% of my patients. If I see say 100 MDS patients, it would be 1 to 2% whom I would be actually able to take them to a allogenic stem cell transplant, which is kind of the curative option. Then once that is not an option, which, and there can be various reasons for that, ranging from the age to the donor availability to the financial issues, and whatnot, and eligibility. In fact, if it is a low risk patient, we usually would, low or intermediate one, we would it would predominantly be the growth factors, or in the 5q deletion space. Lenalidomide is a wonder drug. You just give that oral pill, and the patients. So I had one patient who was getting transfusions for 2 years plus, and say getting a diagnosis of del 5q, and with lenalidomide she is doing well for now of another 5 years. So that's that, but those are a minority. Then our go-to drug is so if it is an anemia predominant phenotype, it would be ESAs would be our frontline therapy in the low risk MDS setting with an anemia predominant phenotype. Obviously, the dose of uh, erythropoietin stimulating agents is much higher than what we would use in a say chronic kidney disease setup. And But in the intermediate 2 and high risk one space, we are pretty much restrict going to one of the hypomethylating agents, say azacitidine or decitabine. If we have if the blasts are higher, and if we have to kind of bridge them to a transplant, we have lately been incorporating venetoclax, particularly if it is a totally inpatient setting, and where the disease flavor is more of a AML type rather than a MDS type. uh, Again, supportive care is very, very important. Transfusions. If there is a lot of dysgranulopoiesis, or if they are neutropenic to say ANCs which are less than 500, antifungals is one which we have to mostly the mold active antifungals, we have to kind of add them to as a prophylaxis strategy. uh, the other drug which a lot of other centers in the West may not be using, but sometimes we do end up using danazol as one of the replacements, or the synthetic androgen as a replacement of ESA, if the patient, if there are affordability issues and they would like to have an oral drug. And So that's pretty much about it. I'm deliberately not mentioning luspatercept here because we know that it's one of the favored drugs in the SF3B1 and the ring sideroblast setting. In fact, the approval is for all low risk MDS, but it's pretty much cost prohibitive and outside the trial, I think less than 10 patients at our center are actually continuing on that drug, uh, basically because of the cost issue.
And I guess one of the recent entrants into the field, imetelstat or Rytelo, which is as it is called in the United States,
Yeah.
is that available yet?
So it's a pretty much recent approval. We are looking forward to that drug, but not yet available. In fact, in our EPO refractory or erythropoietin failed patients, which is not infrequent, we have kind of serious limitations with respect to what we can offer them.
So I think you hinted on some of the unique aspects in the Indian context. Is there anything else that you would like to emphasize that you have not talked about? You've talked about the younger age, you talked about needing to rule out nutritional deficiencies, you've talked about the socioeconomic factors, the cost-effective strategies that you have to adopt. Is there anything that distinguishes urban versus rural or any other aspect that you've not touched upon?
So, if there are a lot of, say, fellows or community physicians who are a kind of who are also uh, listeners to this, one thing which so MDS pretty much is a diagnosis of exclusion, because you are subjecting the patient to a diagnosis which is kind of quote unquote a blood cancer, and it is pretty much remains incurable. So it is a diagnosis of exclusion, and a lot of times you have to be very careful in establishing that clonality part of the uh, pathogenesis. A lot of times your NGS results may be kind of non-contributory, just morphological dysplasia. A lot of our patients are on various alternative medicines, heavy metals, Ayurveda medicines. A lot of them have had anti-tubercular drugs which are there, and then there can be certain mineral deficiencies like copper and whatnot, which can also lead to morphological evidence of dysplasia. So just getting dysplasia in the marrow with cytopenias alone may not be the only feature where one should label a patient as MDS, and one needs to be very careful in ruling out all the reversible causes before that diagnosis is made. So that's one thing. The other thing which kind of we kind of not covered is the hypoplastic uh, form of MDS, which is again which has a reasonable overlap with the another marrow failure, which is aplastic anemia, and then they can have a concomitant PNH, where immunosuppressive therapy with ATG and or cyclosporin with TPORAs may be one of the strategies which we may look at. So that's one thing. The other thing is ruling out. So if you have a younger patient, or where the family history or the phenotype is suggestive, the germline young MDSs also need to be ruled out, unless we are talking about DDX41, which is again a germline but comes at a more elderly age. And vexus is one thing which you need to be aware of. There would be an autoimmune manifestations, then there would be those characteristic vacuoles which are there, and those vexus patients can be they are often referred from say your rheumatology colleagues, or maybe it's an incidental finding on the marrow. So that's one thing which also you need to be aware of, and we have that gene incorporated in our NGS panel for that reason.
And so, where do you see the field needing to move and moving in the years to come?
So yeah, so it's so we have a way to go, I would say, with respect to what we can uh, do to make the lives of our patients better. Uh, Establishment of national registries is one very important aspect that which can kind of inform the local nitty-gritties of the disease per se. And in fact, we are a part of a national registry of myelodysplastic syndrome under the Hematology Cancer Consortium, which has just kind of for the, so we had this registries for all other heme malignancies kind of for maybe 7 years now. And MDS was probably the last one to be looked at, and it's just I would say 3 months old, the HCC MDS registry. So that's where so the national registry where the field is moving forward. We just finalized the case record performers and the ethical approvals for that a month back. So wider access to molecular diagnostics, yeah, it's required. And I would again reiterate, more than that, it's the awareness of the diagnosis among the uh, physicians at length, because they would be the first point of contact for most of our patients. So, and in fact, there are certain labs which are even offering a 3-day NGS to kind of diagnose these disorders. So that's one. Uh, Generics, we have generics which are available for lenalidomide at, I would say, much cheap costs. Even ESAs are not as costly. HMAs, again, a lot of our patients are, so I usually do not face a challenge in continuing with hypomethylating agents again, because a lot of government schemes are there in place where we can kind of support them. Uh, yeah, but the biosimilars for the I would say more novel drugs or fancy drugs such as luspatercept and imetelstat is something which we need to work upon as a nation to come down on those costs. Access to transfusions is again a reasonable challenge, which is as we all know, that transfusion is one of the major components or pillars of supportive care in these patients. And again, I always wonder that India is the most populated country, and still there are challenges in access to transfusions, and a lot of our patients have to travel a reasonable distance just to get a blood transfusion. So that is one more aspect where which needs to be worked upon. Expansion of transplant facilities definitely is required. We Although the number of centers which are offering a stem cell transplant are nearly 150 in the country. But again, uh, so one, it's kind of competitive, where if you will have a acute look and MDS patient side by side, we tend to kind of take up the acute look first because of the urgency of the situation. But we have to understand that most of our patients are dying due to cytopenias and subsequent infections, and transplant is one way where at least the younger ones we would be uh, able to salvage very easily. And transplant in MDS is not as difficult. Most of the times you can get away with a reduced intensity conditioning, and it does have a very satisfying outcome. So transplant facilities is definitely one access barrier which needs to be looked at. Global clinical trial participation, again, uh, is an issue. And I would say that the Asian Indian population is kind of under represented in most of the key trials of the drugs which have been approved till yet. And uh, education, and that's where the podcasts like these with and the efforts of people like you would make, I'm hopeful that they would make a big difference.
So, what would your key takeaways be for the audience? You've given us a very exhaustive picture of the landscape of MDS. I'm grateful to you for that. Any last words of wisdom that you would like to depart with?
So one thing is that you need any cytopenias, uh, MDS is one of the diagnostic possibilities, but it remains a diagnosis of exclusion. You have to be very careful in not missing an MDS, but also at the same time not over diagnosing an MDS, because that is something which we do encounter occasionally in our practice, where uh, it's a transient cytopenia which was a result of, say, a viral infection or a drug, and but somebody got a label of MDS. So it's a diagnosis of exclusion is one key takeaway I would like to take conclude with. And uh, diagnostics and affordable therapy and education is obviously are areas where we need to work in most heme malignancies.
Well, I wish to thank you very much for taking the time to educate our audience about this area. And I hope I can turn to you in the future to talk about other areas in hematological malignancies. Uh, Thank you very much.
Thank you so much, sir. It was indeed a pleasure interacting with you. And I would also, in fact, depart with saying that we can record these in more Indian languages as well, so that we are able to target a more wider audience. Uh,
Definitely. I think
for your
that is a very important thought. And thank you again, and look forward to speaking to you again.
My pleasure. Same here. Thank you, sir.